Welcome back to the deep dive. Today we are doing something remarkably different. Usually we take a stack of articles, research papers, and books, and we just, chat about them in a casual way. But today we have a very specific mission. We are shifting gears into simulation mode.
That's right. For the next hour, I am not just your co-host. I need you to imagine that I am your senior faculty member, the external examiner who has flown in from out of town.
Okay.
And you are a postgraduate student appearing for your MD Anesthesiology final exams at Gujarat University.
I can already feel the tachycardia setting in. The palms are getting a bit sweaty, so the setting is the exam hall.
Precisely. You are sitting across the table from me. You have a blank sheet of paper, a pen, and a glass of water.
Right.
And the topic I've just given you is a classic high-stakes 20-mark long question, non-invasive ventilation.
Okay, NIV. It sounds deceptively simple. We use it every day in the ICU, the PACU, and the ER. It's a bread and butter topic.
It is bread and butter, but that's exactly why it's dangerous in an exam.
Yes.
Because you use it every day, you might get complacent. You might forget the strict physiology or the absolute contraindications. And remember, in the exam, we aren't just checking if you can turn the knobs on the machine.
You want to know the why.
We want to know if you understand why it saves lives and, more importantly, when it might actually kill a patient by delaying necessary intubation.
Right. So our source material today is the heavy hitters. We've synthesized this simulation from Miller's Anesthesia, O's Intensive Care Manual, and the ICU protocols by Chawla and Todi, plus specific notes on exam patterns.
Exactly. We are going to construct the perfect distinction-level answer. We need to cover the definition, the physiology, especially the hemodynamic, the modes, the interface, and the management. If you can master what we discuss in this hour, you will crush the long question, the short notes, and the viva voce.
All right, Professor, I'm ready. Where do we start?
We start where every good answer starts. Part A, the introduction and basic concepts.
Okay.
If you are writing this answer, your opening paragraph needs to be crisp. Define it for me. What is NIV?
Okay, let's unpack this. Non-invasive ventilation, or NIV, is technically defined as the delivery of mechanical ventilatory support to the lungs using techniques that do not require an invasive artificial airway.
Meaning?
That means no endotracheal tube and no tracheostomy tube.
Good. And straight away, you need to highlight the fundamental difference between NIV and invasive mechanical ventilation, or IMV. It's not just about the plastic tube. It's about the interface and the anatomy.
Right. In invasive ventilation, the tube bypasses the upper airway entirely. The nose, the pharynx, the larynx. In NIV, the interface, usually a mask or helmet, interacts with the upper airway.
And what is the clinical implication of that anatomical distinction? Why do we care?
Well, because you aren't bypassing the upper airway, you preserve the patient's physiological defense mechanisms.
Such as?
They can speak, they can swallow to an extent, and most importantly, they can cough and clear their own secretions.
Correct. That preservation of defense mechanisms is the money point. It's why NIV reduces the need for heavy sedation. It avoids VAP.
Ventilator-associated pneumonia.
Ventilator-associated pneumonia. And ultimately shortens ICU length of stay. Miller's Anesthesia emphasizes that VAP reduction is the single biggest statistical driver for using NIV over invasive ventilation in appropriate patients.
Okay.
But, and this is a big but for the exam, what is a prerequisite for all this to work?
The patient has to be cooperative.
Exactly. Unlike invasive ventilation, where you can paralyze a patient and take over completely, NIV is a partnership. It's a handshake.
A handshake, I like that.
If the patient fights the machine, if they're pulling the mask off, or if their airway reflexes are gone, the game is over.
So it's not a tool for an unconscious patient?
Generally not, and we'll come to a key exception later. But for now, yes. It serves as a bridge. It bridges the gap between spontaneous breathing and the invasive ventilator.
And in terms of exam framing, this is a topic that appears across the board, right?
Absolutely. You might get a full 20 marker. Describe the indications, physiological effects, and complications of NIV. You might get short notes on weaning from NIV or NIV interfaces. And in the Viva, it's a favorite because I can show you a mask and ask you to troubleshoot it.
Right. What's this port for? Or what if it's leaking here?
Precisely. So you need to note inside and out.
Okay, so that's the intro. I've defined it, I've contrasted it with invasive, and I've highlighted the importance of airway reflexes and cooperation. Now, let's get into the meat of the answer. Part B, physiology and mechanisms.
This is where you score the extra marks. Most students just list the indications. The distinction candidate explains the mechanism.
The how and why.
Exactly. We need to talk about the physiological effects of NIV. There are three main pillars here. Work of breathing, alveolar ventilation, and hemodynamics. Let's unpack work of breathing first.
Right. So in respiratory failure, the patient is working overtime. The respiratory muscles are consuming a huge amount of oxygen.
Correct. In severe distress, the respiratory muscles can consume up to 25% of the total body oxygen delivery. The diaphragm is exhausted. It's failing. NIV offloads that work. Explain the physics of it.
It provides positive pressure during inspiration. It's essentially assisting the pump.
Go on.
Normally, the diaphragm has to generate negative pressure to pull air in against resistance. With NIV, the machine pushes air in, creating a positive pressure gradient. It overcomes the resistance of the airways and the elastance of the lungs, so the muscles don't have to pull as hard.
Correct. We call that pressure support, or IP, inspiratory positive airway pressure. It reduces the metabolic cost of breathing. You can literally see the accessory muscles in the neck relax when you get it right.
So that's pillar 1, reducing the work of breathing. Now, what about alveolar ventilation?
What's the main gas we're trying to get rid of with ventilation?
Carbon dioxide, CO2.
Right, so how does NIV help with that?
This helps wash out CO2. By increasing the tidal volume, the V-dollar, with that extra pressure boost, we increase minute ventilation, the V-dollars.
And why is that important?
Since dead space is relatively fixed, increasing tidal volume directly improves alveolar ventilation. This is crucial for hypercapnic failure, like in COPD.
Spot on. You're flushing out the CO2, correcting the respiratory acidosis, and hopefully waking the patient up from their CO2 narcosis.
Okay, that makes sense. So number 3 you said was FRC, functional residual capacity.
Yes, FRC. This is the role of EPAP, expiratory positive airway pressure, which you can think of as being analogous to PEEP in invasive ventilation. In respiratory failure, alveoli tend to collapse, leading to atelectasis.
Right. The lung gets boggy and consolidated at the bases.
And why is atelectasis bad for breathing mechanics?
Because collapsed lungs are stiff. They have low compliance. It takes a lot of pressure to pop them open with every single breath.
It's inefficient.
Yeah.
Like trying to inflate a brand new stiff balloon every time instead of one that's already partly aired up.
Okay, good analogy.
By applying HEPAP, we splint the alveoli open at the end of expiration. This recruits FRC, it increases the surface area for gas exchange, and it moves the lung to a more favorable, steeper part of the compliance curve.
Making it easier to inflate with the next breath.
Excellent. So breathing becomes easier because the lung is pre-inflated slightly. Now, I want to take you to the part that really impresses examiners, the hemodynamic implications, the cardiac connection. O's intensive care manual devotes significant space to this. Explain to me how blowing air into the chest affects the heart.
This is fascinating, but it's also where I always get tripped up. It affects both preload and afterload.
Let's take them one at a time. Preload first. What is happening?
Let's look at preload first. When we apply positive pressure to the thorax, we increase intrathoracic pressure. This compresses the great veins, the superior and inferior vena cava,
Resulting in?
a reduction in venous return to the right heart.
Which is good or bad?
It depends on the patient.
Exactly. Explain.
If the patient is hypovolemic, say dehydrated or bleeding, it's bad. It can cause hypotension because the heart runs empty.
You can crash them.
Right. But if the patient is in fluid overload, like acute cardiogenic pulmonary edema, ACPE, it's actually helpful. It reduces right ventricular preload, which eventually reduces left ventricular preload, relieving the congestion.
Exactly. It's often called a bloodless phlebotomy. You are effectively holding blood back in the periphery, stopping it from flooding the lungs. This is a key phrase for your answer.
Bloodless phlebotomy.
Got it. Now the afterload. This is a complex bit.
Right.
How does positive pressure in the chest help the left ventricle, the LV, pump?
Right. So the LV has to pump blood out into the aorta. The cost of this pumping depends on the transmural pressure.
Define that for me.
That's the pressure difference between the inside of the ventricle and the outside thoracic cavity.
Yes. Normally, intrathoracic pressure is negative during inspiration. This negative pressure effectively pulls outward on the LV wall, creating a suction effect that the muscle has to fight against to squeeze blood out. It increases afterload.
So it makes the heart's job harder?
Correct. So when we start NIV, we flip that. We make the intrathoracic pressure positive. This positive pressure pushes on the outside of the LV.
It's like an external squeeze helping the heart.
Let's simplify that for the listener. Think of the heart trying to squeeze blood out of the chest. If the pressure inside the chest is higher, it acts like a helper, squeezing the heart from the outside, helping it eject blood into the high-pressure systemic circulation. It effectively reduces the afterload the LV has to overcome.
So for a failing heart, NIV is like an invisible hand helping it pump.
That is a beautiful analogy. That is why NIV is magic for left ventricular failure. It reduces preload so the heart isn't flooded and reduces afterload so the heart pumps easier.
Wow.
If you explain this clearly in your exam using terms like transmural pressure gradient, you are winning. You're showing a deep physiological understanding.
So to summarize physiology for the essay, we decrease the work of breathing via IP. We increase alveolar ventilation to wash out CO2. We recruit FRC via EPAP. And we optimize hemodynamics by reducing preload and afterload.
That is a distinction level summary. Perfect.
Okay.
Now, we need to talk about the types of positive pressure. We hear CPAP and BiPAP all the time. What's the difference scientifically?
This brings us to Part C modes and interfaces. Let's stick to the physics first. CPAP stands for continuous positive airway pressure.
What does the waveform look like, if you had to draw it?
It's a flat line. The pressure is constant during inspiration and expiration. If I set it to 10 7H2O, it stays at 10 whether I'm breathing in or out.
Correct. It's like breathing with your head sticking out of a moving car window. The pressure is always pushing in. Does CPAP ventilate the patient?
Strictly speaking, no.
Why not?
It doesn't create a pressure difference to move air in and out. The patient has to do all the work of breathing themselves. It just splints the airway open.
Exactly. This is a crucial exam distinction. CPAP recruits alveoli, increases FRC, and keeps the airway open for obstructive sleep apnea, OSA. But it does not actively assist the tidal volume.
So it oxygenates, but it doesn't ventilate.
Perfect. It oxygenates, but it doesn't ventilate. Remember that. Now contrast that with BiPAP.
Bi-level positive airway pressure. The clue is in the name. 2 levels.
Right. Tell me about them.
Right. You have a high pressure when the patient breathes in IPAP, and a lower pressure when they breathe out EPAP.
And the difference between them, what do we call that?
That's the pressure support, the delta P. It's IPAP minus EPOP. That difference is the driving force that actually moves air into the lung.
Precisely. So BiPAP ventilates. It helps remove CO2. CPAP just oxygenates and recruits.
This seems like a really important point to make clear.
It is fundamental. If you have a patient who is just hypoxic, so type 1 respiratory failure, CPAP might be enough. Think of cardiogenic pulmonary edema.
Right.
If they are hypercapnic retaining CO2, which is type 2 failure, you need BiPAP to help them blow it off. Think of your COPD patient.
That's a clear rule of thumb. Now let's talk about the hardware, the interfaces. The sources say the interface is the most common cause of failure.
It is. It's the Achilles heel of NIV. You can have the perfect settings, but if the mask leaks or the patient is in agony because of a pressure sore, you fail.
We have the nasal mask, the Oronasal or full face mask, and the helmet.
In the acute setting emergency room, ICU, which one is your go-to?
The Oronasal or full face mask.
Why?
Because when patients are in respiratory distress, they are usually mouth breathing. It's a natural response. If you use a nasal mask, the air just goes in the nose and leaks out of their open mouth. You lose a pressure, the therapy fails.
Correct. The Oronasal mask covers the nose and mouth. It's the standard for acute respiratory failure. But what's the risk?
Aspiration is the big one. If they vomit, it's trapped in the mask. There's nowhere for it to go but down.
A huge risk. What else?
Communication is hard. And claustrophobia is a real issue. A lot of patients just can't tolerate it.
Yes. Now tell me about the helmet. It looks like a spacesuit hood. IC Protocols mentions it specifically. When do we use that?
It's great for long-term use because it doesn't touch the face, so no skin necrosis on the nose bridge. The classic pressure sore.
The classic spot, yes.
Yeah.
And it fits anyone, regardless of face shape. But what are the physiological downsides of that big bucket?
Dead space. The internal volume is huge. There is a risk of CO2 rebreathing.
How do you combat them?
You need very high gas flows to wash out the CO2 from the helmet. Also, the trigger delay, it takes a split second longer for the machine to sense the patient's breath because the volume is so compressible it can feel out of sync.
Excellent. So for the exam, nasal mask for chronic home use or very mild cases, Oronasal for acute failure, helmet for long-term tolerance or facial burns.
Okay, moving on to Part D indications. This is the exam favorite. If I get asked, what are the indications for NIV, I can't just list them randomly. I need to prioritize them based on evidence.
Absolutely. You must categorize them. Start with the grade A evidence, the absolute home runs.
That would be acute exacerbation of COPD and acute cardiogenic pulmonary edema.
Correct. For COPD, NIV is the standard of care. It reduces mortality, and it reduces intubation rates. What are the specific ABG criteria to start it in COPD?
We look for a pH less than 7.35 and a PaCO2 greater than 45 mmHg, so respiratory acidosis.
Good. And for pulmonary edema?
It works by that hemodynamic mechanism we discussed, pushing fluid out of the alveoli and offloading the heart. Both CPAP and BiPAP work well here, though some studies suggest CPAP is just as good and maybe simpler.
That's a good point. Often just the PEEP effect from CPAP is enough to turn the corner. What about other indications, the grade B or C ones?
Pneumonia and ARDS are on the list, but with caution.
Why with caution?
The failure rate is higher because the lung is stiff and consolidated. You're not just dealing with bronchospasm or fluid, you're dealing with inflammation and shunt.
Right, and there's a real danger of P-cellia, which we'll get to.
What else? Postoperative respiratory failure, especially after abdominal or thoracic surgery.
Why does it work in post-op patients?
Because pain prevents deep breathing. They're splinting, they take shallow breaths, leading to atelectasis. NIV splints the chest and allows for deep breaths without as much muscle effort. It helps them get over that initial painful period.
Yes, and let's not forget weaning. We have this concept of extubation to NIV.
Right. For high-risk COPD patients, you don't wait for them to fail after extubation. You extubate them directly onto NIV to prevent reintubation. This is the facilitated weaning strategy.
Excellent. Now flip the coin. Part D, Section 8. Contraindications. This is where you save a life. You are in the Viva. The examiner gives you a clinical scenario. A 45-year-old male, vomiting blood, GCS7. Do you start NIV?
Absolutely not.
Why not? List the contraindications.
It's absolute contraindications. Respiratory arrest is obvious, but the inability to protect the airway like a low GCS or active vomiting GI bleeding is a hard no. You'll just blow the vomit into their lungs.
You're guaranteeing an aspiration pneumonia. What about hemodynamic instability? Patient is in shock on high-dose noradrenaline.
That's a strong relative contraindication. As we said, NIV reduces venous return. If they are already in shock, NIV can crash their blood pressure further.
Good. You must stabilize them first. What about facial trauma?
Can't get a seal. So facial burns, trauma, recent facial surgery, it's just not going to work.
Correct. Now, there is one famous exception to the low GCS rule. It's a trap examiners love. A patient comes in drowsy, GCS9, but they have severe COTD. Do you intubate immediately?
Ah, the CO2 narcosis trap.
Explain it.
In this specific case, the drowsiness might be caused by the high CO2. It's a reversible encephalopathy. If we can wash out the CO2 with NIV, they might wake up.
So what's your plan?
So we can try a short, supervised trial of NIV, but we watch them like a hawk.
How long?
An hour, maybe 2 at most. If their GCS isn't improving, if they aren't waking up as the CO2 comes down, then we failed the trial and we intubate.
Perfect. That nuance is what gets you the high marks. It shows clinical judgment, not just memorization.
Okay, Part E, initiation and management. I've decided to start NIV. How do I actually do it? I can't just slap the mask on and crank it to 20.
No, you will terrify the patient and you'll fail before you even begin. This is the handshake phase.
So it's about communication.
It's vital. You need to explain it to them. This is a mask to help you breathe. It'll feel like a strong wind. Reassure them. Hold the mask gently against their face first. Don't strap it tightly immediately. Let them get used to the airflow.
Get them to synchronize with it.
Exactly. Coach them. Breathe with the machine.
And for settings, let's talk BiPAP settings.
We usually start in spontaneous timed ST mode. This means the patient triggers breaths, but if they stop, the machine gives a backup rate.
Okay.
Start the IP8, the inspiratory pressure low, maybe 8 to 10 centimetal H2O, and the EPAP expiratory around 4 or 5 centimetal H2O.
So starting settings of, say, 10/5.
A very common starting point. And then we titrate.
How do you titrate? What are your goals?
You titrate the IPAP up. What is your target? What are you looking for?
I want a good tidal volume, say 6 T8 mil plug ideal body weight. I want to see their chest moving well and their respiratory rate coming down from, say, 35 to the low 20s.
Good. You were watching the patient. What if their oxygen is low, their SATs are 85%? Which knob do you turn?
For oxygenation, I increase the EPAP or the FiO2.
And if their CO2 is high on the blood gas?
Then I need more ventilation, so I increase the IPAP to create a bigger gap, a bigger pressure support.
Precisely. Remember, the gap removes the CO2. The EPP fixes the O2. It's a simple way to remember it.
The gap for gas. EPP/PPO2. Got it.
Now, how do we monitor them? Is it a set-and-forget therapy?
Definitely not.
So what do you do?
The first hour is the golden hour. You stay at the bedside, you look at the patient, are they struggling less? Is the respiratory rate dropping? Is their heart rate coming down? Are they using their accessory muscles less?
Clinical signs of success. What about objective data?
You check an ABG at 1 hour.
And what defines success on that ABG?
Improvement in pH and a drop in PaQ2. ICU protocols is very clear on this. If the pH is the same or worse after an hour or two, that is a strong predictor of failure. You should already be thinking about your exit strategy, which is intubation. Which leads us nicely into Part F, complications and failure. We mentioned skin breakdown on the nasal bridge. What else can go wrong?
Gastric distension, aerophagia. If you blow air in at pressures higher than 25 centimeter H2O, you overcome the lower esophageal sphincter pressure.
And the air goes into the stomach instead of the lungs.
Well, it goes to both, but a lot goes into the stomach. It gets bloated and uncomfortable.
Which increases the risk of vomiting and aspiration.
Exactly. So we try to keep peak pressures below 25 centimeters H2O if possible. If you must go higher, you might need a nasogastric tube to vent the stomach, though that can break the mask seal, which is its own problem.
A balancing act. What about other complications?
Eye irritation from air leaking up from the top of the mask. It can cause conjunctivitis, and of course the claustrophobia and anxiety we mentioned. Sometimes you need a very small dose of a sedative like dexmedetomidine to help them tolerate it.
Okay, let's talk about NIV failure. This is a critical concept. How do we spot it early?
As I mentioned, no improvement in pH or respiratory rate after 1-2 hours. That's a huge red flag. Also, look at the patient's consciousness. If they are getting more drowsy, it's failing. If they are fighting the mask, it's failing.
The outline mentions the late failure trap. What is that?
Yes, this is the patient who looks better initially on day 1. You think you've won, but then they crash 48 hours later.
Why does that happen?
It's dangerous because we often miss it. It's usually due to retained secretions. They can't cough effectively through the mask. Or we miss the underlying diagnosis like a pulmonary embolism or untreated heart failure.
So the initial improvement was temporary.
It was a temporary fix for a problem that was still festering underneath.
We also need to talk about PCLE. You mentioned it earlier.
Patient self-inflicted lung injury. This is a hot topic, especially after COVID. If a patient is on NIV, but still taking massive gasping breaths, generating huge negative intrathoracic pressures, they can damage their own lungs. The machine is pushing in, and they're pulling like crazy. The resulting transpulmonary pressures can be enormous and injurious.
So even though it's non-invasive, you can still get ventilator-induced lung injury, or in this case, patient-induced.
Exactly. If the work of breathing hasn't settled, if they're still gasping for air, the NIV is failing, and you are potentially hurting the lungs.
In point 13, escalation. The golden rule.
Do not delay intubation.
Say that again.
Do not delay intubation. There is plenty of data showing that patients who fail NIV and are intubated late have a much higher mortality than those intubated early. NIV is a bridge, not a destination. If the bridge is collapsing, get off it.
Powerful image. Okay, Part G, special situations. We touched on post-op. What about the obese patient with OSA?
These patients are a huge challenge for us. They often have obesity hypoventilation syndrome, or OHS. They have a heavy chest wall, reduced compliance, and their upper airway is prone to collapse.
So after surgery, when they're lying flat and have had opioids?
It's a perfect storm.
Yeah.
When they lie flat, their FRC collapses due to the weight. Their tongue falls back. NIV is essential for them in the perioperative period.
We ramp them up.
Yes. The ramp position, or reverse Trendelenburg, head up, plus NIV. It stents their upper airway open to treat the OSA, and it offloads that heavy chest wall, making it easier to breathe. It's mandatory in the PCU for these patients to prevent atelectasis and reintubation.
And what about sepsis?
Be very careful. This is a major pitfall.
Why?
If a patient is panting because they have metabolic acidosis, lactic acidosis from sepsis, NAV won't fix the root cause.
They're breathing fast for a reason.
They are breathing fast to compensate for the apnea of their blood. It's a physiological response. Putting a mask on might just exhaust them while the underlying sepsis gets worse. They usually need intubation, resuscitation, and treatment of the sepsis.
And ARDS?
Controversial. You can use it in very mild ARDS, but you must monitor them incredibly closely for failure and for PCLE. Generally, moderate to severe ARDS is an indication for early intubation.
Finally, Part H, exam integration. We need to package this for the examiner. We talked about a comparison table for CPAP versus BiPAP.
Yes, visualize the table on your answer sheet. Column 1, CPAP, 1 pressure, constant, focus. Oxygenation and airway patency used for type 1 failure like ACKE. Column 2, BiPAP, 2 pressures. IPAP, focus. ventilation and work of breathing, used for type 2 failure, like COPD.
And NIV versus invasive.
Another great table, NIV. Preserves speech swallow, less infection, less sedation, intermittent application possible.
Cons for NIV.
Leaks, risk of aspiration, requires patient cooperation.
And invasive.
Secure airway, protects against aspiration, allows deep sedation or paralysis, precise control over every breath. But it comes with the risks of VAP, sedation complications, and laryngeal injury.
Got it. The outline mentions Viva traps, the secretion trap.
Yes. The examiner says, the patient has a weak cough and lots of thick yellow sputum. Should we try NIV?
And the answer is?
The candidate answers, no, sir. Copious secretions that the patient cannot clear are a contraindication because the mask traps them. They will aspirate. They need an invasive airway for effective suctioning, or perhaps a mini-tract bronchoscopy.
And the setup diagram.
You might be asked to draw the circuit. It's simple, but people make mistakes. Remember to draw the exhalation port.
The leak port.
It's often a whisper swivel or a series of small holes in the mask itself. If you block that port or use the wrong mask without one, the patient can't exhale CO2. It's a closed circuit. The air has to get out somewhere. If you forget to draw the leak port, you fail the station. It's a critical safety feature.
And the pressure waveform diagram for BiPAP?
Also very high yield. Draw the axis, pressure on the axis, time on the x-axis, show the baseline EPAP level, then the curve rising to the IPAP level during inspiration and falling back to EPAP for expiration. You can even draw a little slope to represent the rise time setting. Shows you understand the mechanics.
Okay. We've covered a huge amount of ground. Let's wrap up with a summary for the listeners, our students. How do I structure that final 20-mark answer?
Start with a definition, then a section on physiological effects, that's your WOB, FRC, and hemodynamics. Then a big section on indications, categorized by strength of evidence. Then contraindications, absolute and relative.
Okay.
Then a short section on initiation and settings. And finally, a section on monitoring, complications, and criteria for failure. If you hit all those points logically, you have a complete answer.
Let's do a rapid-fire recap of the absolute must-know points.
Let's do it.
Point 1.
NIV interacts with the upper airway. Invasive bypasses it. This preserves host defenses.
2.
The core physiology is unloading the respiratory muscles via IPA and recruiting alveoli via EPA. Hemodynamics. It reduces preload and afterload. This is why it's magic for heart failure.
4.
COPD and pulmonary edema are the grade A, home run indications.
5.
Contraindications. Remember, coma, vomiting, hemodynamic instability, and copious secretions. The big ones.
6.
Monitor your patient closely. Check the pH and their clinical state at 1 hour. This is your decision point.
And the final, most important point.
Do not delay intubation if it is failing. Delayed intubation kills.
That is a solid framework.
If you structure your 20-mark answer like that, intro, physiology, indications, protocol, failure criteria, you won't just pass, you'll top the exam.
Pen for the Viva.
Be confident. Know your waveforms. Know your interfaces. And always assess the patient, not just the machine. Look at the patient. Do they look better? That's your most important monitor.
Thank you, Professor. I genuinely feel much more prepared to face the examiners now.
Good luck. Go draw those waveforms. Practice explaining the transmural pressure gradient.
And to our listeners, thanks for diving deep with us. Whether you're prepping for Gujarat University exams or just keeping your clinical skills sharp, we hope this simulation helped.
Now, here's a final thought to mull over. We talked about NIV as a bridge to recovery or a bridge to intubation. But what about its role as a ceiling of care? In a patient with end-stage respiratory disease who is not a candidate for intubation, how do you ethically use NIV for palliation, knowing it won't change the ultimate outcome? That's a question not just of physiology, but of philosophy.
A heavy but important question, something to think about. We'll see you on the next Deep Dive.